I am Dr. William Sunstein of NSPC Brain and Spine Surgery.
And I'm Rich Obedian of Island Spine and Sports.
This morning we have a special guest. We have Dr. Craig Baldenhofer, who is a plastic surgeon, who is here to join us and discuss some of the things that he does with us in the operating room in the care of our patients. And we're very happy to have you on board today.
Yeah, we've been working with Craig for, I would say, at least 15 years, right?
About 15 years. We started...
Probably closer to 14.
14.
Don't make me so old yet.
Yes, you're a youngster.
We started, we met Dr. Baldenhofer, well, you met him first, actually, at Plainview Hospital.
Well, you know, it's interesting. When I first met Dr. Baldenhofer, I was looking for somebody to help us with our complex spine closures. And I asked a bunch of plastic surgeons to help, and most of them were not interested. And Craig was just starting out as a new attending, and the person he was working for said, please, please, please throw my junior attending some cases. So I said, sure. And we hit it off, and it turned out to be really a great experience for both, I think, for all three of us. And it was so successful that attending subsequently wanted to get in on the action, and he asked, can I start doing some of your spine cases? And at that point, we were kind of committed to Craig and very loyal to him, and he's done an outstanding job. So I had to sadly tell him, unfortunately, we're going to stick with Craig.
I've had to tell other plastic surgeons who wanted to get in on our spine cases as well. And I said, no, we are very loyal to Dr. Baldenhofer. He does a fabulous job, and we're very lucky to have him.
Yeah, we're loyal with good reason. And I'm going to hand it over to Craig in a moment, but our complication rate, especially regarding wound infections, wound dehiscence, they're low to begin with, but they've been dramatically lower since we've incorporated Dr. Baldenhofer into our surgeries. So without further ado, Craig, why don't you tell us about some of your training, how you came into being a plastic surgeon, and specifically what your role is in complex spine cases.
And also, if you want,
the Lord said, "Let there be light."
Yes.
And also, you can talk about some of the other things you do in addition to just closing expertly our wounds after our spine surgery.
Correct. Dr. Baldenhofer does not just do complex spine cases, but he also has a excellent practice of his own, doing everything from breast reductions to facelifts, and we'll talk about and liposuction. We'll talk more about that as well.
Great. Well, thank you for having me.
We're glad you can make it. We've been trying to do this for a while.
Thrilled to be here. You guys look great.
All right, we're the Spine Bros.
So my name's Craig Baldenhofer. I'm a board-certified plastic surgeon. I've been in practice for about 14 years in private practice. My training, I initially am from New Orleans and went to college at LSU. Wanted to go to med school, but wasn't quite there yet, so I went to grad school in Washington, D.C. at American University and got a master's. And then from that, I did a fellowship, a pre-doctoral fellowship at the NIH in molecular genetics.
You're a real academic. You're not just...
I was. This is how I learned I don't want to be an academic. I love operating. I do not like research.
What did you do your master's in?
Developmental biology.
Okay, so you're always sort of scientific.
Mm-hmm. Yes. So actually, the primary investigator I was working with at the NIH left to go to Georgetown and set up a new lab, and I actually went with him.
Followed him.
And worked at Georgetown for a short period of time while I was waiting to go to med school. And then I went to med school in Louisiana at LSU Shreveport. During that time, I always knew I wanted to be in New York, and I had met my wife, I think, while I was in D.C., and she lived in New York, so I had only applied to general surgery residencies in New York.
Wow.
And I started my general surgery residency and quickly learned I am not a general surgeon. I was not really looking forward to a career as a general surgeon.
Was it the smell of general surgery that offended you the most, or?
Listen, for the guys who love it, they love it. As it turns out, I really enjoy operating on young, healthy people.
But you have to take, but in doing plastic surgery, you have to do general surgery first anyway, right?
So the entire system has changed. The traditional model when I started was you did 5 years of general. Typically, the year of research was sprinkled in. Following that, you then went on to a 2 to 3 year plastic surgery fellowship.
Right.
Over the course of the last 15 years, it's been more common that people just do a straight 7 of general surgery. I mean, I'm sorry, a straight 7 of plastic surgery.
Really?
So you
So
start,
people
so
are-
you match into plastic straight from medical school.
There's a
Yes.
plastic surgery residency now.
There is.
So you're not
And
board
that-
certified in general surgery, then you just go for plastic surgery.
Exactly. So back when I started plastics residency, it was still about 50-50. But I think the majority today are just a straight 7. So I'm one of the last generation of people who did the sort of traditional general surgery
You did a full
followed
5-year
by
general surgery residency
But-
followed by the fellowship.
therein lies why I am special. I realized so early that I didn't want to do general that I went into plastics after 3.5 years of general surgery.
Where did you do your general surgery residency?
Cabrini.
Cabrini. And they've closed that hospital
They
down
did.
now. That was part of the Catholic.
I was on a lifeboat out of there in order to start my plastics
Did
residency.
they shut it while you were a resident?
Mm-hmm.
So then,
I
where did
saw
you,
the-
so
I
then
saw it
you saw the
coming.
writing on the wall.
Where did you go for your plastics?
I went to OHSU in Oregon,
That's right, you
Portland,
went to-
Oregon. So that was my
Oregon.
first experience out on the West Coast.
Big foray outside of New York. That's a far cry from New York.
Yeah.
You went from Louisiana
That's
to
Portland?
to Washington to New York to Oregon.
And your wife came with you.
And she came with me.
That's loyal of her.
I actually, I don't even think we were married at that point. Well, no, we were married. We got married when I was in general surgery. Forgive me for saying that.
Yeah.
But yeah, she thankfully followed. And
Well, I think you made the right choice. Plastics is a very clean, elegant field, which is really the opposite of general surgery. You're really dealing with the worst of the worst.
I would never say that.
The
It's just not for me.
Well, some people
it's-
actually derive a lot of pleasure in doing general surgery.
Yeah. No, I mean, it's very important. It just was not for me.
I remember the first time I was a medical student in a general surgery case. First day and I said, "What is that horrible smell?" And the resident looks at me and goes, "That's called general surgery, my friend." And the smell of poop really pervades the operating room. I guess that's what you're operating on, the colon and
Yeah. So
Yeah,
anytime
cancer.
anybody asks me, about hernia repairs and things like that during my cases, I always say, if I ever see that, I've done something wrong.
Well, that's actually
I
not a
bring
good
in
thing
the
if you're
general
You're
surgeon.
happy not to see that.
If you're smelling that during the operation, I mean something's wrong actually, because you don't want to spill that stuff basically in the operating room.
Yeah.
Otherwise, you cause a major
Yeah.
infection.
Yeah,
So,
sometimes.
just like you guys bring me in to help out with the things that I'm good at, I bring in the general surgeon to help out with the things that need to be done when I'm doing cases.
So oftentimes patients will ask me, "Why do you need a plastic surgeon in a case?" And sometimes even hospital higher ups will question, "What is the need for a plastic surgeon?" And you can expound on this, but there's been a number. I know we point out there's been a number of studies that have shown the complication rate is dramatically lower
Yes.
when a plastic surgery is involved, especially in complex spine cases. So
Correct.
what do you do differently?
Well, so plastic surgery at its core is basically restoring form and function. And as plastic surgeons, we operate basically from head to toe. We operate on bones, we operate on soft tissue, we operate on nerves, we operate on vessels. It's a very broad training. So we really do know what to expect with wound healing and what the tenets of keeping, optimizing wound healing are, and this tissue handling. So when it comes to complex spine cases, we're just trying to essentially recreate the form and function that the spine had. So matching like to like, closing dead space. Oftentimes when you put a foreign body in, like orthopedic hardware, you can't just have that stuff hanging out in a dead space. You have to have well vascularized tissue on top of it to make sure that an adequate blood supply is keeping infection at bay, and you just don't have a huge dead space there. So through the use of things like local tissue rearrangement or even muscle flap coverage, we were able to reconstruct the defect to as close to how it should be, and cover everything with a well-vascularized blood supply.
Why do you think that, there's a lot of different spine surgeons that use plastic surgery as well. What do you think, we talk about this a lot, but what do you think differentiates your technique versus other plastic surgery techniques that really allow our wound infection rate or complication rate to be so low?
I can only speculate because I have my own technique that I've kind of refined over the last 14 years. I do things much differently these days than I did in the past. One of the things that was very popular for a lot of closures back in the day is called wide undermining, to make sure you have these tension-free closures. And I have actually shied away from that greatly. And I kind of use a reconstructive ladder where I do the least invasive thing first in order to save a lifeboat for something else later on in case we need it. And that involves, trying to do as little as possible at the initial operation in order to ensure that if, heaven forbid, we need to come back, there are a lot of options available to us.
Does that wide undermining create more of a dead space?
It does. So even in the minimal dead space that I try to create in order just to mobilize everything to where it's covering the hardware, I use techniques that have become popular in plastic surgery for other surgeries like abdominoplasties called progressive tension sutures, which help close the dead space. So you're closing that rather than just closing the muscle and closing the subcutaneous tissues and skin on top of, a big 10, 20 centimeter dead space where fluid could collect and you put a drain in to hope that it doesn't. I use quilting sutures to tack down that space so that it doesn't even give the fluid a chance to collect, or at least as minimally as possible.
I never liked the technique of undermining and creating these muscle flasks because, as you mentioned, you're really creating a new dead space on top of your dead space that you have.
So
already.
I try to mobilize everything as much as I can, keeping the blood supply, and then close all that dead space.
The other thing I like about the way you close the wounds is you don't put too many drains in. We had worked with some other plastic surgeons in the past who would put routinely 4, 5, 6 drains in a wound, and it just seemed to me that our infection rate was actually higher with the more drains. There was more chance of bacteria coming in and out, and just using one deep and one superficial drain, I think, is a much better way to go. Which is the minimalist, less is more.
Yeah,
because when people are emptying, the nurses are emptying the drains, or
it's open to the air.
It's open to the air. You have many.
It's another portal for infection.
More drains.
It's more.
You have more
foreign
chances.
Bodies in the healing wound.
Another side of inflammation.
There's other little things that have popped up over the years. Like back when we started, there were no bio patches. Now we have bio patches. So who knows how that would have affected the rates in the past too.
And so to tell the audience what a biopatch is exactly.
It's a little disc that goes around the exit of a small drain that is either silver impregnated or has some antimicrobial properties that allows for just reduction of the bacterial load on the skin near where it's
that exit
coming
side
out.
of the drain.
Does it help at all?
I believe so. I use it all the time. There's a couple of things that I've decided.
Is this automatic on all drains that they have that, or only
No, I have to ask
specifically ask for it?
I ask for
you have
it.
to add. I think you have to add it.
Yeah, it's a cost, but again,
They didn't exist when we were first closing wounds 25 years ago.
I don't recall that.
I do tell patients when they come into the office that they basically are getting kind of the Rolls Royce of spine closures when it comes to all the things that are available to us. Because
do you hear that? Our spine cases are basically
it's not the Kia. It's the
Well, you want the best, and there are other techniques that you can use on the skin. Other
some people just staple stuff closed, and it takes it's quick.
When I used to close wounds routinely, I used to just use staples. That's what I did. I didn't make it so there was reabsorbable sutures.
Barbed sutures are a very big part of my practice now.
I don't remember that, but I certainly
remember we have a selective memory, but the complication rate was higher.
Yeah,
and certainly the wounds weren't as nice.
So,
or as cosmetic.
again, just bringing in stuff from the plastic surgery sphere into the spine surgery sphere. These techniques like the quilting sutures, which were used in abdominoplasties, the use of barbed sutures, which were not on the market 14 years ago. I always use sort of a belt and suspenders style of closure, where I literally, the worst thing that can happen is for me to be staring at somebody's spinal cord 2 weeks later. And I don't ever want that to happen.
Neither do we.
So,
actually.
and it doesn't happen.
And thankfully, we have not seen that.
Yes. So, I
We've been very,
close
very
the muscle,
happy.
I close the fascia, then I reinforce that with barbed sutures, because individual sutures, if they pop, or a running suture, which is, a very quick style of closure that a lot of people would use, if that pops and it's not a barbed suture, the whole thing unravels.
Right.
And if that happens early on, it's just not good. So, we use interrupted sutures followed by a running barbed sutures. So there's a double layer closure, then the quilting sutures in order to make sure that the dead space is closed. And then various sutures, the expensive sutures basically for the skin, which will keep things together. And then again, the very important dressings, because I spend almost as much time putting on nice dressings as I do with the operation. Because with the advent of this new Prineo style closures, where initially it was brought to market and sold to plastic surgeons as, you don't even need to use a running subcuticular. You just put the Prineo on and it's done. But again, I like belt and suspenders.
Yeah, so
I will
What is
still
Prineo?
run.
Explain what is Prineo?
So it's an occlusive cyanoacrylate dressing that will cover the wound. But back
Like
in
a
the
glue.
day, it's like a Dermabond glue, skin
Right.
glue. But then some very smart person who I really appreciate, figured out, well, everybody's just putting steri-strips on top of this. So why don't we create one dressing that is essentially a
Impregnates
steri-strip and glue, which will cover the
You should have
entire
invented that.
wound.
Well,
But it's nice because it keeps tension off the healing wound, because what makes bad scars is
Is it tension?
tension and movement across,
Right.
this collagen deposition that's supposed to be happening and make the wound heal. But if you can essentially cast it like you would a broken bone
you
while
let
it's
the
healing,
collagen
you get
do
a
what
nice.
it has to do in a normal, natural way.
Right.
Keeps it less tension.
It-
And then we have some patients are prone to getting hypertrophic wounds, keloid scars, and things like that. And we tell them before that there are techniques the plastic surgeon can use to minimize scar formation or hypertrophic scars like keloids.
Sure. There's two ways of going about that are the least invasive. I.e., if you know that somebody has like a
history of it.
really, and we should really delve into the difference between what a hypertrophic scar is and what a keloid scar is. So a hypertrophic scar is like a thick ropey scar, and nobody wants that. And darker skinned individuals tend to be prone to those.
Is that because they have more muscle in the skin?
Honestly, I don't know.
But there's more tension, obviously. That some
No,
causes
it's just
scar to
some
be
people I think genetically are just more prone to getting a hypertrophic scar. And then there's keloids, which are scars that actually grow outside the boundaries of what the initial injury was. So a lot of what we have seen in the past is more of a hypertrophic scar than a keloid. But if you see a keloid, you'll never forget a keloid. It is like a fungating mass out of, to bring up a general surgery term, out of the scar.
And you can inject them with steroids, which is like, so is there,
Exactly.
is there an inflammatory component that's causing the keloid? Must be something like that. Why would the steroid work?
Yeah. So that's where you have to be careful, though, because, of course, steroids can inhibit wound healing as well. Right. So if it's a known history, then I can give them a small amount at the time of the closure and then just monitor it afterwards. And you can give it separate it out by about 4 weeks, every little thing to keep it down.
After the wound is sort of healed up.
Once it's healed.
And the location of the wound also matters as far as the scar.
Some places are much more prone to hypertrophic scars and keloids than others.
I guess it's really most important when it's a scar that people can see.
Yeah.
Like in spine, that would be like an anterior cervical or a neck surgery from the front. And patients get very uptight about this.
I actually, when I tell a patient that they need surgery for an anterior cervical, when we're going to make a scar for the front of your neck, I always, in addition, say, it's your lucky day because we also have a plastic surgeon to close your wound to make it beautiful. And I think people are pretty happy about that, actually.
Yeah.
It helps sell them on the surgery. Yeah.
For anterior cervicals, occasionally with difficult patients, you guys need to make a vertical incision. And I'm sure you know from your orthopedic training, linear incisions going across a moving joint cause contractures, and you can limit the motion. So having that on your neck is very difficult. So,
you're doing like a Z
we do a Z-plasty to make sure that we don't ever have to come back to the OR.
That lessens the tension.
It puts soft, pliable tissue interposed between a healing scar because all scars contract. And if it's a scar across a joint, that contraction can be significant enough that it'll limit motion.
And the scars, surprisingly, don't look bad on the Z.
No,
in the patients who need that, in the patients who need the Z, it isn't bad at all. But those are for the very rare patient who's morbidly obese or has a very short neck. And is difficult to get the exposure, especially at C6-7 or C7T1, a low level that's hard to access through the front.
You never want to, compromise your exposure on these cases, but you're sort of caught between a rock and a hard place, and although we don't like using a vertical incision.
Sometimes it's necessary,
and that's why to do this, and it makes it a lot easier on these patients who are morbidly obese, have very short necks. So having a plastic surgeon around to deal with this really is very helpful.
Plus, we also tend to make the incision in the front of the neck through the normal skin folds.
Yeah,
so it's not going to be a noticeable. Usually, it's not a noticeable scar anyway.
Right,
which is helpful, especially with your excellent closure.
Thank you.
But you do more than just because often patients will say, "Oh, there's going to be a plastic surgeon there. Can he do my liposuction? Can he do my breast reduction at the same time?" And sadly, he cannot.
Yeah, we generally don't encourage them to have multiple.
A lot of times it's different positions.
I have converted quite a few people. As it turns out, a lot of people with back pain, not only do they have some sort of compression, they also have large breasts. And that contributes to back pain, neck pain. And one of the things that I can do for them is breast reduction, which would help alleviate that.
It's very hard to tell a patient in the office, you need that. It's
going to become increasingly more easy because there was just a big New York Times article about the rise in breast reductions because women are, it's actually smaller breasts are becoming more in
style,
vogue,
more in fashion.
Yeah, because they're limited. I mean, women that they can't do the athletic events they want to do. That's one thing, and and it does contribute to back pain.
It's back pain, neck pain, shoulder grooving, rashes under the breast, particularly in the summer. It's difficult to wear some clothes. They can't exercise, and so out of all the operations I do, I would say that breast reductions is the highest satisfaction surgery, both for me and the patient.
Yeah, I've had a number of patients I've sent to you who've come to me with upper back pain or mid back pain, who clearly need a breast reduction. And thankfully, insurance companies are now reimbursing if there's a medical reason for it.
Oh yeah,
it's not purely cosmetic.
Well, if the New York Times says to do it, then then the insurance company is going to follow now.
That's my favorite medical journal.
That's where I get all my information, my definitive information.
So my private practice is evolved over the years. You start out being a jack of all trades, taking ER call and doing hand surgery and whatever comes your way. But, within the last 5 years, I've really just decided I'm going to do what I enjoy doing. And that is largely mommy makeovers. So it's women between the ages of 20 to 50 who need either breast reductions, breast lifts, breast augmentations, or tummy tucks, liposuction. And I would say that is probably about 80% of what I am doing.
But you also do breast augmentation and
breast augmentation
and facial surgery too.
Upper lower eyelids and facelifts.
But no nose jobs.
No, that is the one area that I always refer out.
It's kind of it's like scoliosis surgery. It's kind of like a specialty within, that kind of, you do them all the time. Or don't do them, basically.
Yeah. So, that's kind of the way it is for the spine surgery. The nice thing that I like about it is that it allows me some weeks to operate 5 days a week. I will have my regular Tuesday, Fridays, but I also book cases on Monday, Wednesday, Thursday. And that's a
cosmetic
good week.
practice.
And it
That's a
just
great
keeps
week.
me busy. There
Hopefully
are
that will
some
continue.
guys, when the cosmetic stuff will start to wane, then they could be twiddling their thumbs for a while. And I don't ever want to do that. I want to be operating every week.
Right.
Where are your offices?
I guess. Well, go ahead. I was going to
Yeah.
say. I guess spine surgery is more recession proof,
Yeah,
and when the times are good, people are willing to spend more on their aesthetics.
exactly. So I have offices in Manhattan on 21st Street between 5th and 6th, in Long Island, in Huntington on Park Avenue, and then additionally, I just started seeing patients in Massapequa on Friday mornings before our cases.
Oh, nice.
That's very
So
good.
that's why I'm going to need the 30-minute heads up.
All right, no problem.
But
That's
that actually
But
makes it
it's
much
really-
more
it-
convenient for you.
It makes it much more convenient for my patient population, which I've determined actually comes from the South Shore quite significantly. So it saves them from having to make a trip up to Huntington.
Also, I mean, I just being in practice for so long, there's a North Shore and there's the South Shore in Long Island. The South Shore is so much more dense in terms of patients, and I think it's a better, catchment area for a doctor, especially from what you do, to attract patients because there's just so many.
Yeah, it's actually getting very busy in the mornings.
That's good. That's good. Yeah, if Muhammad doesn't come to the mountain, or the mountain doesn't come to Muhammad, then Muhammad will come to the mountain. So that's good that you're available.
You always have to look for new cheese. My partner is big on this. The famous book, Who Moved My Cheese? So you have to go to the new cheese. You have to find that. You can't just depend on everything just coming to you because things change and you just, your cheese has moved somewhere else. You got to find that. So that's good that you branched out to Massapequa. It's a big area.
Yeah. So, when patients come, I almost have too many choices for them. So I'm trying to narrow that down because I actually, I'm privileged at the Northwell system, meaning Lenox Hill and Manhattan Eye and Ear. So when patients are coming for insurance-based cases, typically breast reductions, I'll do them at Manhattan Eye and Ear, which is the outpatient surgery center for Lenox Hill. If they're doing something cosmetic in the city, I work on the Upper East Side at a office-based surgery center, and there's a beautiful new surgery center downtown that I'm going to start working at in Tribeca.
Oh, very nice.
Additionally, in Long Island, I'm associated with, as you know, NYU, Winthrop, Langone system, as well as St. Francis Hospital, so the Catholic system. I have block time at St. Francis that I book my mommy makeovers at.
That's great.
And then additionally, we have 2 Quad A certified ORs in the Huntington office. So, there's
So you have your own OR in the office itself.
2 Quad A ORs, yeah. And it's downstairs. It's a separate facility connected by a stairwell from the office that we can go down.
That's
So
great.
it's good.
So people are doing mommy makeovers as outpatients. They're doing in the morning. They're going home the same day. They're not spending the night in the hospital.
So, yes, but my personal preference for my patients, I like to limit my operative time. As you guys know, operative time and complication rates are directly correlated. The longer somebody's on the table, the higher the complication rates.
Absolutely.
I think that's a
Across the board with any surgery.
Yeah.
big
and-
deal. It's how
So,
fast you get them off the
when
table.
I'm dealing with purely elective surgeries, I prefer to try to limit them to 4 hours. And I will tell you, early ambulation is key, getting patients up and moving the day of surgery. So for me, I can do a breast and a tummy in 4 hours, but I like that added protection of if in the middle of the night the patient has a question, I don't want them to worry. I like for them to have somebody there. So that's why at St. Francis, it typically will involve an overnight stay or 23-hour admission. So I can do one of these big cases,
And they
have a PA
drains as well.
there. What's that?
And they have drains as well.
Breasts never have drains
Breast-
in my practice. Tummies typically do. And it's a surprisingly alarming amount of fluid comes out of those drains on these liposuction tummy tuck cases.
Yeah.
And so these patients have somebody there, outside the door. They're monitored. And if they have questions, somebody can answer them. They don't have their kids walking into the bedroom and bothering them. It's just, I sleep well at night knowing that they are being monitored and they So I see them the next morning, bright and early,
there
and
was
send
a
them home.
plastic surgeon on Long Island who was doing cases and putting them up in Ohika Castle, which is like almost like a hotel situation in the North Shore.
So
He was paying for that himself?
Yeah, but he was charging. I mean,
He was charging-
indirectly, he was charging a lot for the patients. So they were,
it's very common in plastic surgery to actually either have an overnight stay. We actually have one in the Huntington office, but you have to hire a private duty nurse to
I mean,
be
you really
there.
don't want to send a patient out in a coma after surgery. I mean, like, I mean,
Yeah.
well, there have been plastic. I mean, plastic surgery can be a major operation. I mean, there can be major, even liposuction can cause you to hit a vessel, or
Heaven forbid.
there was a case at about 15, 20 years ago in Plainview where somebody came to the ER after having had a liposuction by a gastroenterologist who took a weekend course in removal of fat from the lower extremities, and he did this procedure, and he must have nailed the femoral artery. And it was a very sad case because it was a young woman under 40 years old with a child who ended up with an above-knee amputation after this happened. It's, you can't take any of these kind of procedures lightly. You really need somebody who's board certified, has a lot of experience, has done thousands of cases. And that's, it's a terrible thing that somebody goes to I don't know if that's still.
Oh,
if
it's
that's still a thing.
rampant. It is, unfortunately, everybody is trying to get in on
the
a
bandwagon.
fee-for-service cosmetic practice, but the reality is they're all not properly trained. And
Well,
you
even-
can learn a technique, but managing the complications is a completely different beast. So a lot of people think they know what they're doing, and in reality, they have no idea how to deal with
So I think the
results.
general rule is if you're seeking out to have these procedures done, you go to a plastic.
Well,
You
even
go to a
even
board
surgeon,
certified.
right.
So then you have
Even
to make the
surgeon.
distinction between what is a plastic surgeon and what is a cosmetic surgeon.
Right.
So as you know, there is the American Board of Medical Specialties, which is basically the people who say, you're an orthopedic surgeon and you're a neurosurgeon.
you got to
I
go
am a
through rigorous
plastic
testing
surgeon.
and training to be board certified.
So people who want to circumvent and present themselves to the public as cosmetic surgeons when they are not actually plastic surgeons, there's I hate to say it, there's a sham board called the American Board of Cosmetic Surgery
So the American
that is not recognized by the American Board of Medical Specialties that will basically give them
ridiculous.
their weekend course certificate and put it on their website and fool people into thinking that their surgeon is properly trained.
It's really a terrible thing, and and for the average patient, they're not necessarily aware of the differences, and they just say,
Not at
"Oh, he's
all.
board certified," because they're told to look for board certification, and they don't know what a bogus board versus a legit board
Exactly.
is, and it can be very dangerous.
I remember many years ago, my partner used to like to talk about the busiest spine surgeon in the city is a GI surgeon. They were doing.
Yeah.
They were basically literally.
I think he was at Lenox Hill.
They were trained. They were being trained to do these discectomies. I guess they were percutaneous or something like that.
Yeah,
but that's pretty. It's pretty crazy, to think that
It's insane.
specialist could actually.
They're
float
doing it for the money. It's just
into-
greed.
That's
into
the
that
wild
specialty.
That's the wild thing about medicine is like once you get that MD behind your name, like
Whatever you want.
technically you could do whatever you want. Now your malpractice
But
isn't
even-
necessarily going to cover you if you do something wrong.
Because it says on your
But-
certificate you are board certified in medicine and surgery, so you
Right.
technically could do anything you want to do if you just get
Right,
the
right.
training.
Right.
Yeah.
I mean, but there are doctors, family practice physicians, radiologists, PAs, general who are doing Botox in their office or things like that, and they maybe that's not as major as doing a liposuction. They can cause some damage as well.
Yeah,
Or fillers.
there's definitely issues with going to people who are not trained in the proper anatomy, or I shouldn't say trained in everybody goes to med school, everybody learns a couple of muscles, but like to really know what the effects are and how to deal with the complications is like wherein lies that rigorous training, as opposed to just learning how to stick a needle into somebody's forehead.
Well, we're capable of closing a wound as well, but you have the better training to minimize those complications.
Right.
That's why we recognize our limitations and we want to go with somebody who's really an expert who's going to help us.
And if there's a problem, we work as a team. We have you available if there's a problem with the patient.
For sure.
And,
Always happy to see somebody in the office if there's a issue or, One of the other things I wanted to bring up was just this idea of the doctors out there doing things in their office versus doing them in the hospital. Like, according to New York law, you are technically supposed to be credentialed to do the operations that you're doing in the office in
a hospital.
But there's no way that a pediatrician doing liposuction in their office
Is that happening?
Oh, yes.
Pediatricians are doing liposuction on
Not on
adults,
kids, on
children.
adults.
On adults.
So, like, it's
It's
two types of
That
scope
I've
of
never heard of.
practice errors.
I can't imagine that
happening.
being the case.
I promise you it's happened.
I
I
believe
don't know if
you.
it's still happening in Long Island, but I've definitely
I
looked
blame,
up this
I blame it
person.
on the government.
Anything can happen in Long
And
Island.
the reimbursement, of these poor
Nothing would
pediatricians
surprise me.
who, they send in their bills for $10 for my children, and I always pay it because I always
That's
feel
so sporting
bad
of you.
because they depend on these $10, 20, and how do you survive? So they start doing liposuction on adults. It's
Get your
kinda crazy.
dentists doing Botox as well. That's one of those things where I don't mind that sort of scope of practice creep because it's
OBGYNs are doing it too.
pretty benign.
Yes.
And it's
ENT,
ENTs are doing nose jobs.
they're doing a lot of stuff.
I actually do think ENTs are well trained to do rhinoplasty. I don't mind that at all.
Oh, then it comes to rhinoplasty, yes.
I think-
but liposuction.
But when they
I
start
don't
like
know.
moving into tummy tucks, that's where I start to say, well, now you're actually not in the realm of what you
That's
should
right.
be doing.
There is an ENT plastic surgery fellowship, I think, or where they
Oh, yeah.
specialize.
So
in
no,
plastic-
it's called the American Board of Facial Plastic Surgery, and it is again.
and is that recognized by the American Board of Medical Specialties?
That I would have to look up. I'm not sure, but I technically could have become part of that because part of my historical practice was for a while I was doing a lot of facial reconstruction with Mohs defects from a Mohs surgeon,
Right,
dermatologist.
Cancer or
Would
something.
create a big defect on the face, and then I would, use various local tissue rearrangements or skin grafts in order to close those. And I looked into, I'm operating on faces like 2 days a week. How do I actually become a facial? Turns out you can be any, I guess it's probably like plastic surgery, ENT, or maybe even general. But if you do enough cases and present it to the board, you then become
That sounds a little
board
bogus.
Well, okay. Yeah, I agree. But I was like, well, I'm doing it. Why not just get that double board certification, even though it's not really.
There was a push for a while to have an American Board of Spinal Surgery, but it's kind of fell by the wayside. For a while, there was a group that was pushing for it because there's neurosurgeons and orthopedic surgeons and I guess some GI guys that were doing spinal surgery.
I just don't understand that one, but that's fine.
That was an outlier. But now I think it's more you're either board certified in orthopedics or neurosurgery to do spine.
Yeah, I mean,
really-
not that
it really is
medicine can't evolve. There are definitely new things popping up that maybe should be folded into it.
But maybe spine surgery should be more like plastic surgery in that you do 2 or 3 years of orthopedics or neurosurgery and then go on to just
Yeah,
specialize in spine for at least 3 or 4
right.
years.
Instead of
Like,
spending.
when was the
all
last
this
time you did a wrist? Like,
Well, he does
You're-
a lot more
I do some-
general
yeah.
stuff than I do.
I still see distal radius
other
fractures
than
in the office.
spine.
do you,
Yeah.
do you really?
Yeah, I saw one yesterday.
Yeah, he takes care of everything. I send all
so-
my.
Is your preference to do spine, or do you
Problems there.
want to do?
Preference is to do spine.
Right.
But the truth is that you have this knowledge after doing an orthopedic surgery residency for 4 or 5 years, and why throw it away?
We used to do a lot.
Well, you have to
of,
like what you're doing.
If I think that something needs an like I know like I said before, I know my limitations. If I think someone's going to need an operation or is a little more complex, might have a different kind of a fracture, in some of the carpal bones, like a scaphoid fracture, or something that would need a hand surgeon, then I'm happy to refer. I have a lot of good friends who are hand surgeons that I will send to immediately. For a simple distal
agree.
radius fracture, it's simple enough that I can handle that.
I feel bad that I
you-
did all this training in brain and I don't do it anymore. But I feel like you can't be a jack of every trade.
Exactly.
And I have guys in my group who really specialize in brain. Why not let them do the brain stuff? And it's funny because we used to do a lot of work in training with the plastic surgeons in craniofacial reconstructions, particularly with
Craniosynostosis.
craniosynostosis. And it was really the plastic surgeon who came in and really did the arrangement of the bones, the skull.
Yeah, the
structure.
neurosurgeon comes in and does the
Kinda
we
just-
called it the zip to
Yeah,
remove
we
the bones.
we removed the
and-
bone and we kind of just take
plus
a second and
you
see
were
for
at
them.
you were at Einstein with Dr. Goodrich.
Dr. Goodrich was
who's famous for separating Siamese twins
but
that
he
were
always
connected at the head.
worked. He always worked with the famous plastic surgeon, Dr. Argamasso. I remember, and he was incredible what he was able to do for the rearrangement of the parts of the skull, and then he reconstructed. So there's a lot of
Skull's very complex. You also have the sinuses, and you have vessels, and you have brain matter.
There's a lot of need, I think, for co-surgery in a lot of specialties. Like for us, we work together as an orthopedic and neurosurgeon. I think that we bring the best of both worlds to patients, and I think that working with other specialties as well, with plastic surgery, really just gives the patient the best outcome that I think we can offer a patient, because at least from what I've seen over the last 15 years or 14 years, pretty nice looking wounds, I have to say.
Well, you said before you offer the Rolls Royce of treatment.
Right.
So why shouldn't patients have that?
And the difference between a 50-cent staple and a $5 suture, it's really not that much in the long run, and I'd rather have the best result.
Yeah.
Because an infection and a complication like that costs a lot more.
Oh yeah,
it does.
And that'll cost the hospital a lot more. Cost the patient a lot more. And plus, it costs the doctor's grief. Usually, these things happen on the weekends.
Right. We don't love to come in the middle of the night to wash out a wound. We never do that. What do you find some of the most challenging cases that you encounter? Whether it's
reoperations, people who have had previous radiation really affects the pliability of the tissues and just the overall delivery of the healing factors that somebody needs in order to.
They're the poorest of the poor protoplasm.
Or protoplasm.
What do you think is necessary to help prevent complications from closing a wound that's been radiated, or a patient who is immunocompromised, or something that's
diabetic?
Diabetic has a higher increased risk of wound complications.
Just one of the things that I learned in plastic surgery school was from one of my attendings who said, whenever you're coming into a case as the plastic surgeon, even if somebody has come in before you and said they've cleaned up the wound,
don't believe them.
Go in and just debride.
You always chide us on burning too much tissue with the cautery.
It's all about the tissue handling, ensuring that you're not leaving behind just non-vascular stuff in the wound that is going to be a nidus for infection.
Right.
So, I always clean up even more after you guys leave. I always hemostase extensively after you guys leave.
Do you curse us when we leave the wound?
Only when things start spurting out, and I go, "Oh, I'm glad I was here."
Plastic surgeon.
It's like a second set of eyes. You guys are operating for an hour or two, focusing on what you need to do to make the best operation. And then, but you're tired by then, I'm sure. You don't want to think about, what's best for getting the wound closed. And that's where I come in. And it's a fresh set of eyes who can, look at it, recognize what the problem is, how we're going to fix it, how I'm going to keep a lifeboat for, heaven forbid, I need to come back. Thank goodness.
It does give us an opportunity to have some lunch.
That's true. You know what? I actually forgot, if I want to bring it back to, I skipped on my training because I actually, after
so you did
plastic surgery school, I went to a fellowship in microvascular breast reconstruction and aesthetics.
Oh, I didn't realize. Okay, so you kept going after your fellowship.
I kept going after my fellowship.
You did a second fellowship, and that was also in Oregon?
So how many years?
No, that was actually in Baltimore.
So how many years did you actually train in plastic surgery? I know you did general surgery.
Exactly.
Then what was the time?
I was probably the last. I meant to mention this earlier when we were talking about the various ways of going about stuff. I am probably the very last person to have done sort of an accelerated plastic surgery program in that I did only 3 years of general instead of the traditional 5 or 6 with research, and then went straight into a plastics program that was traditionally reserved for people who had done
5 years.
all the 5 years.
And how
6
long
years.
was that
2-year
program?
program.
It was a 2-year program.
You did
And then
5?
after that, I was like, you know what? I think I need more training.
Then you went
Like
to the microvascular.
And I went to the
fellowship.
microvascular and aesthetics
So
fellowship.
you really did 6 years of training total. After from start of general.
From medical school.
Yeah, 6 or 7.
6, okay.
Yeah. And like I said, it was the most accelerated route out of all the people that I knew. So that those
That's why
extra
you're so young.
years where
You started.
I was actually doing research and doing other things when people had started med school, I made up those years getting into practice because I like jumped exactly to where I wanted to be, what I wanted to do.
So it worked out well.
It did work out well. So
Lucky.
I'm the appropriate age for where I am.
Yeah.
Maybe we really
But I've done
do
a
it
lot
all
of
wrong
research.
in our country and the system. You know, we spend this 4 years in medical school. Now they just did a study.
And NYU of Long Island is only 3 years of medical
I
school.
was just going to say they did a recent study actually comparing 3 years to 4 years of medical school and found that the medical students perform just as well 3 year versus 4. Because when you think about it, in the 4th year, you're really kind of doing elective stuff. You're worried about
You're
the
really
next
your
stage.
goal is like matching into a program.
And once you're matched, you're kind of like coasting there in medical school. So is the 4th year really so necessary? Maybe the 3 years should be maybe a little more intense, but they're already pretty intense. But I mean, the way they do it in Europe and other countries, I mean, you kind of go right into your
You do 6
specialty.
years straight from high school.
Right. So really,
Yeah.
we waste a lot of time maybe in doing things we really don't need to do when you see what the outcome is of what you end up doing.
If I could have changed it, I would have folded in an MBA at the time of training because I actually know several people who got an MBA during either the interval between
College and medical school?
college and medical school or fellowship and plastic surgery school. And I think if you want to be in private practice, that is super important.
You also
And-
you said you did research. I mean, a lot of residencies have a year of research. So you kind of did that.
But I did it before.
Right. You did it before versus during. So you really kind of ended up in the same time, frame.
Exactly.
Yeah.
That's really good. I mean, so we obviously are working with a very well-trained plastic surgeon who
Well traveled for
has
sure. I've
has
been all over the country.
and understands different, operating rooms and it's very interesting hearing how people end up coming to where they are now.
Well, did you find Oregon to be a little more advanced than New York in some of their?
I don't know how to say this
We don't
without
insult half the country.
No, Oregon was fantastic. It was the facilities were state of the art, amazing. And with OHSU is on a hill with a tram that goes down to the outpatient surgery centers for the plastic surgeons, and it's a lovely tram ride down with beautiful sunsets and mountains, and the ORs are
I've never been to
huge. It's, because the West Coast, everything's pretty new.
Right. They
New
have more
York,
space.
everything is kind of like retrofitted from,
I think that's very good if you train in New York, particularly during your residency. I think it's always good to try to do if you're going to do a fellowship, try to do it in some other part of the country because you realize that things are done differently in other parts of the
For sure.
country.
Well, even in New York, things are different. I went to medical school at Columbia, did my residency, did my internship at NYU, residency at joint diseases, and then a fellowship at HSS. And each hospital had a totally different personality, even though they may have only been separated by 20, 30 blocks. They were like completely different styles and techniques.
But there's still a New Yorkness about these training places, and
You have to-
there's an
They were all,
attitude
they were all
of New York.
prestigious places and had an attitude.
Yeah.
But if you go to someplace else, there was just the way the nurses are, the way the way people cavort themselves in the operating room. Like I trained my fellowship in Tampa in the South. I mean, things are totally different done there.
Yeah, it's very interesting because the degree of autonomy that people get in training is very different, whether it's a inner city public hospital that you're
more
at,
autonomy at an inner city hospital.
or if you're at a
Private
prestigious private facility with a lot of private practice attendings who are a little less likely to give somebody who's in training
Right.
the opportunity to operate on their private patients.
Although I think that's changing now too. I think the autonomy that we had as residents 30 years ago, 25 years ago, is much higher than what the residents who are in training now are getting. Because now, even if they're in a city hospital, there are laws now that require the attending to be in the operating room at the time of the operation, and so they're getting less.
They're getting
independence.
less independent, right? And
Less
they're not,
independence.
and you learn a lot when you're independent. I mean, when I was, at Jacoby training, I mean, we did everything there.
You're forced to think on your feet. You're running the show basically.
I mean,
as
you
the
had
resident.
an attending, but available, but still, you really did. You started the cases yourself. You learned how
It matures
do
you.
stuff.
You realize what you need, what you don't need. You're not relying on another surgeon above you to tell you what has to be there.
No matter how much
You're kind of calling the shots.
I haven't even
Exactly.
thought about this stuff for a long time since it's out of my purview now. But there's the fact that like residency hours are capped these days as opposed to
That was unheard of. Nobody had any sympathy for you. I mean,
Exactly.
we were up for 48 hours. That's
will be on-
bad.
I
Be on
hate to
call 3
sound like
days in
the
a
old
row.
man's shaking my fist at the clouds, but like it really is
You were on call from Friday for the entire weekend. Friday night, Saturday night,
a
Sunday
different
night.
generation.
Yeah, I just,
Now you get off 24 hours after you've been on call. So
I just can't believe how good they have it. But in the end, it's not so good for them because they're not going to get that independence. And no matter how much you watch,
or do you think they're a little bit
surgery-
weaker? The new attendings are a little bit weaker
I
as
think
they come out.
I
They don't have the same experience.
I'm not going to say that, but I think that as much as you observe something, unless you're doing it yourself, you're not learning.
I
You really do.
know that there is a definite decrease in the amount of private doctors, private practice physicians coming out. It's almost as if
Well,
everybody's been shepherded into working for a hospital system.
There's a lot of reasons for that, and particularly in terms of reimbursement and insurance. But I think the pendulum is going to swing.
We will see.
I
When I
think it
started,
is.
I would say 25% of doctors work for hospitals and 75% went to private practice, and now it's flipped.
Mhm.
Probably 75, 80% are going for hospitals. Although it's probably less in plastic surgery. Plastic surgery still has
You still have an elective thing.
practice, and you're not tied to a hospital as a plastic surgeon.
you're not tied to
there's
insurances.
plastic surgery is so broad. Even within plastic surgery, there are aesthetics fellowships. There's microvascular
reconstruction,
fellowships.
yeah.
There's
Mohs fellowships.
Well, most is traditionally a dermatologist, but there's craniofacial fellowships. And all of these can lead to kind of wildly different practices.
And fellowships.
Yeah.
Well, hopefully we will continue our private practice because there's nothing better than being your own boss, as far as I'm concerned. And I think that really can be the kind of doctor you want to be without the constraints of a system on you. In any event,
You can still offer Rolls-Royce care when you're in practice for yourself. Because when the hospital is your boss, they're going to dictate to you, we don't want you to use this system. We don't really want you to use the more expensive suture. We want you to use the staples, or we want you to use something that might be subpar. And you can argue with them to your heart's content that the results are better, but there are some bean counters in these institutions who can make it difficult, and it's a battle that you have to constantly fight. And so you have a little by being independent, you can say, well, if you don't let me do it the way I want to do it, I'm going to go elsewhere. So you have some leverage.
and I think the patients appreciate being able to directly communicate to their attending doctor, and not always do they appreciate just getting answered by some of the other healthcare providers.
And
they want their attending surgeon, and when you're in private practice, you get to have that interaction with the patient.
These things really matter because, believe it or not, after a patient has back surgery, they'll come to me and they'll say, "You did a great job. The wound looks fantastic."
And you don't almost want to say like, "Oh well, it wasn't really me."
Well, but it creates a perception that you go above and beyond, that you do the right thing, and it's not just the superficial area that you're seeing, but also what happened on the inside, because they're also feeling better, they're walking better, they have less pain, the numbness and weakness is hopefully improved. All these factors play into creating a successful outcome, and then that leads to more patients because the word gets around that you guys do a good job.
So everybody basically realize that this is a excellent plastic surgeon, and you should definitely come check out Dr. Baldenhofer's practice when you need something that involves plastic surgery.
It's something to ask your physician if you're contemplating back surgery. Do you have a plastic surgeon that will help close the wound? And see what they say.
Thank you very much for coming here today.
Oh, it was
Dr.
my pleasure. I
Baldenhofer.
really enjoyed it.
Yeah, no, it was excellent. We're glad to have you, and hopefully we can do it again in the future.
Yeah, for sure.
Absolutely.
Thank you very much.
Thank you.